When a patient comes with a seizure, it's customary to divide into provoked and unprovoked seizure. This distinction matters because it determines the recurrence risk of seizures and it determines the need of long-term anti-epileptic treatment. Now let's first discuss provoked seizure. It's also called acute symptomatic seizure. Occur due to temporary identifiable cause. The brain is reacting. The brain is not epileptic by per se. The common causes are metabolic. It could be hypoglycemia, it could be hyponatremia, or it could be uremia. Or it could be a toxic mediated, like alcohol withdrawal state or acute alcohol intoxication. It could be drug overdose. Rarely it could be structural as well, acute structural causes like stroke, head trauma, CNS infection like meningitis or encephalitis. Or it could be part of systemic illness like high-grade fever, sepsis, or hypoxia. An example is a patient presents with a sodium of 108 and develops a seizure. Correct the sodium, the seizure is very unlikely to recur. So it's not epilepsy. Now this should be contrasted with unprovoked seizure, where there is no immediate identifiable cause without an acute trigger. It is due to chronic brain predisposition. Brain is intrinsically a seizure prone and these people usually need anti-epileptic long term. So the causes are usually a remote stroke scar, a tumor, cortical dysplasias, or genetic predisposition syndromes which are associated with seizures. An example is a patient comes with a seizure. Initial labs are normal, an acute CT done is normal. However, a subsequent MRI shows gliosis or a gliotic scar. This patient is having an unprovoked seizure and he needs long-term antiepileptic. The clinical differentiation is that in provoked, the trigger is usually present. In unprovoked, it is not there. Recurrent risk in provoked is low while high in that unprovoked. So treating the underlying cause will prevent further seizures in a provoked seizure. So the bedside rule is that whenever somebody comes with a seizure, if there is a cause, remove the cause and the seizure doesn't recur. However, if there is no cause, brain remains at high risk of recurrent seizures and they need long-term antiepileptic. So a seizure may be a reaction or a disease. It should be distinguished.